great when it works right, and then sometimes it doesn't. So anyways, for anybody who doesn't know me, my name is Brittany McKinley, and I'm a PGY3 preventive medicine resident. I've been working with Dr. Cunningham this past year, who, if you don't know her, she's one of our fabulous OBGYNs here at UK. She actually just left us shortly ago onto bigger and better things. But we decided to put together this lecture because through some of my clinical work and work in the public health sector, I've found that there continues to be a relatively high rate of unintended pregnancies and underutilization of contraceptives. My research has shown that some of the barriers to contraceptive prescribing includes things like provider time, but also general knowledge and comfort in talking to younger people about things like sexual activity. So Dr. Cunningham has agreed to do this lecture with me so that we can assess how we are doing here at UK in terms of prescribing contraceptives. There are going to be some survey questions delivered throughout the lecture. They are totally voluntary, and all information collected is anonymous. Additionally, many of the responses show aggregate information only. But answering these questions will make for a very interesting and interactive lecture. So if you are willing to participate, we would love if you could log on now, if you haven't already, to menti.com and use the code 238842. That information's right up here at the top. And for those of you participating, we'll start with a few warm-up questions before I hand over the audio to Dr. Cunningham. So we'll move on. Oh, let's see. There we go. Okay. All right, so we'll start with an easy question. It's not a trick question. What PGY year are you?
So now you guys get the idea of how this works. It's completely anonymous, so you can answer anything you want to. We're going to have some that will be fill in the blanks, and then some will be multiple choice as well.
Perfect. And it looks like everyone responds, so we have a good number of people joining today, so I'm really glad about that. And then, so here's the next set of questions. How many IUDs have you placed? Nexplanons have you inserted? And prescriptions for birth control have you written this week? The IUDs and Nexplanons could be ever placed. And this shows an aggregate. Okay. So some. All right. Next slide. Okay, so how important do you think contraceptive counseling is, from not at all to very important? How comfortable do you feel discussing sexual activity? How comfortable do you feel discussing sexual orientation? And how comfortable do you feel discussing number of partners? There we go. All right. Looks like a lot of people feel really comfortable, so that's good. Awesome. All right. And then how comfortable do you feel discussing this variety of contraceptive methods? So we've got the barrier method at the top, we've got oral contraceptives, patches and NuvaRing, we've got the injections, we've got the Nexplanon IUDs. So let's see. So it looks like we're really comfortable with the barrier methods and such as condoms. A little less so maybe with Depo and the Nexplanon patches. Okay. Good. So this will help us focus where we want to spend our time talking today. All right. Okay, over to Dr. Cunningham.
So one of the reasons that we wanted to give this talk is to answer some questions. You know, I have a lot of friends that I went to med school with, and they are internal medicine, OB, GYN, peds, family practice. And a lot of times I'll get people that will text me and say, oh, I've got this patient and I don't know which kind of contraception to give. So I'm hoping that during the talk today, you'll get some of those questions answered. But you'll also realize that it's okay to have an OBGYN in your back pocket and And we are happy to answer those questions for you. That is one of our roles. Okay, we are also going to talk a little bit about LARCs and a little bit about some, we're going to have a little debate about some issues around contraception as well. We have sent out some online resources, but I also want guys to know that all of these slides can be made available to you after the talk. We want to make sure that you have as many resources as possible. I'm a big fan of watching videos, and so I've got a huge list of YouTube videos that would be appropriate for contraceptive counseling issues. But I'm also a big fan of podcasts. And so on our next slide, we've got a nice long list of one of my favorite podcasters is Dr. Hector Chapa. Dr. Chapa and I were in residency together. He's a year younger than me, and he has nice little 7 to 10 minute quick and easy podcasts. And there's a huge number of them on adolescent issues and contraception issues, which sometimes was where the questions lie. So if you are a podcast fan, I highly recommend these, and we will send out these resources as well. But one of the most important sources that I use is the summary chart, the chart of U.S. medical eligibility criteria for contraceptive use. So this is a chart that was put out by the CDC and gives you guidelines for when you have a contraindication, which is the best contraceptive to use, if you can use any at all. So I really highly recommend that you guys screenshot and put this on your work computer so you have it easy access, or take a picture of it on your phone, and that way you can always have it in your back pocket. It's super handy to me, and when I'm in clinic, I probably use it a couple of times a day, just to get an idea of which contraceptions are the best ones for everyone. It is color coded, and so after you get used to the color coding, you'll understand that all you have to do is just avoid those pink and reds and you'll be okay. But we are actually going to go through a little bit of a case and give you an idea of how I use it in clinic. So if I had a 28-year-old who came in looking for contraception, she's got normal monthly menses, they last 6 days, she's got a new sexual partner and she's interested in getting a birth control, but she has a history of what she calls a clot that was in her leg after she was playing soccer. She broke her leg, was immobile for a while, and then was told that she got a clot in her leg. So I think this is a perfect example of how I would use this chart. I would try to figure out, was this a superficial venous thrombosis or was it deep venous thrombosis? And then I can go to my chart and actually look at which contraceptive methods would be appropriate for her, and then I can counsel her appropriately. So this is super handy. Sometimes you'll get some people that you're like, oh my goodness, I don't know which one I can give. And so you can just whip out your chart. One little side note to keep in mind is that migraines are very specific with aura or without aura. And so if you have migraines without aura, you can be a little looser on the guidelines than the migraines with aura. So that's just a little side note. Okay, so hopefully we're going to have a little bit of discussion today. And I know it can be awkward to discuss on Zoom, so we would love verbal discussion if anybody would like to speak out and switch over and switch their mic on. But we would also like some written discussion so that it can be a little bit more anonymous if you so choose. So you'll see how this works a little bit. We're going to just talk a little and type a little at the same time. Okay, so to get started, how frequently do you think that birth control and other medications should be prescribed? So right now, most pharmacists will fill 3 months at a time. It's because of the insurance company. So even if I write for 12 months of pills, the patient will have to go either once a month or once every 3 months to get her refills. So my question is this really the way we should be doing things? Should we be forcing our patients to go back to the pharmacist once a month or every 3 months? Or should we hand her a stack of 6, 12, even more pills and say, you can have as many as you're willing to pay for? So this is, I think, a question about birth control. And then you could say, well, maybe this is a question about everything. I mean, do you really, I know you want to check the blood pressure on your patient, but do you really need them to go in once a month to the pharmacist Or how often do you think that they should see you? Maybe some of these meds, maybe their statins should be a year-long med and you give them a year's supply. So on that note, most people are familiar with NuvaRing. It is a once a month ring that goes up inside the vagina. It's placed by the patient and removed once a month. But whoever invented the pill must have thought that we all wanted to have periods every month. And so you can use it continuously and not have a period at all. But again, because of this question of, well, maybe we should give people a year's supply, they have come up with one of the newest contraceptive methods on the market, which is Anovera. It is a progestin and an estrogen that releases hormones through the vaginal walls for a complete year. And that way you only have to pay one copay and it lasts all year long. You can take it out for sex if you choose and you put it right back in afterwards, or you can just obviously leave it in. Now, when it comes to cost, you know, cost is a big question nowadays. When I was in training, I never thought I'd have to talk so much about cost and coupons and savings plans, but the truth is that is a big part of compliance with our patients. So oral contraceptives, and by most insurance plans, are completely free. Basically, it's a zero copay. If it's not on the formulary, then it may be a copay of $30 to $120 per month. So if you look at this chart, it also tells you that the Anovera is insanely expensive. The Walgreens price, if you're paying cash, is $2,400. But if you can get it covered, so you can say that perhaps they failed another method, or you feel like they're high risk and this is the best method for them to be on, that perhaps you could get it covered with a copay of $0. As of April of 2019, there were pharmacists in 13 states and the District of Columbia who could legally prescribe hormone contraceptive. And so this is kind of a national push right now. Freethepill.org is one example of this, where they think that birth control should be over the counter or directly prescribed by pharmacists and not requiring a medical prescription. And so we were hoping to get some opinions from you guys of what you think about that, and whether or not birth control should be over the counter. So should progestin-only pills be over the counter? They're considered lower risk than the estrogen-based pills. Or should we have all birth control be over the counter? What about Depo-Provera shots? Do you really need to go to a doctor to get approval for Depo-Provera shots? Or should we just let the pharmacist decide if someone's appropriate and let them give the shot? Or should we have the patients learn how to give their own shots? You know, you guys give insulin to people all the time and people learn how to give shots. So maybe we should be asking people to self-administer all of their shots. So any thoughts about open access? So you can see I've typed in test and you can see that it pops up and it's completely anonymous. So if you have any comments about open access and why we should or shouldn't do it, we were hoping to get a little bit of a discussion going real quick. You know, a lot of times the question is can you adequately counsel someone about the risks and benefits on one instance and then hope that they will go and buy it over the counter themselves and self-select when it's not an inappropriate prescription? Can we count on our patients' education to make their own good decisions for themselves? DVT risk is an excellent question. I think that for me is the biggest thought. A lot of people are familiar with the morning after pill, which is basically the equivalent of about 8 birth control pills that you take all at the same time. The efficacy of that is pretty good if you're thin, but if you have a body weight over 157 pounds, the efficacy is actually pretty poor. So we've got this over-the-counter thing. We're giving 8 birth control pills all at the same time. What is our DVT risk with that? And again, in the thin patient where it's going to work, it's probably pretty low risk. But if they had other risk factors, I do think that's a question. Yep, stroke risk with migraines. And again, maybe if we could do enough education, maybe we could have these patients self-select. But I do think that that is an issue. Stroke risk is also a concern. You ready for the next one, Britt?
Yeah.
So one thing is self-administering. We've found a study done in Malawi where they looked at 364 women who were randomly assigned to groups, and the self-administer group was much more compliant with our birth control, which is of course what we all want. We want our patients to be compliant. 73% versus 45% compliance. So perhaps self-administration of medication is actually a better way to go. Stroke risk. So just to put in perspective what the stroke risk is, we have a baseline stroke risk. Of course, we all have a risk of having some kind of venous thromboembolism. And when you take a birth control pill, that risk goes up. Now, depending on which birth control pill you take and what your other factors are, it may be higher or lower. Obviously, it's going to be higher in your smokers, higher in your older age. But to put it in perspective, getting pregnant is much more risky for venous thromboembolism than taking a birth control pill. And postpartum is by far our highest risk point at all. Teenagers, some questions sometimes pop up about, well, you know, I trust some of my patients, but some of my patients, I'm not sure they're going to make the best decisions for themselves. And teenagers tend to be, of course, a high risk group. Obviously, they are also a sexually active group, though, with 42% of females having had sexual intercourse from ages 15 to 19 in one study. 82% of adolescents at risk for unattended pregnancy were using contraception, but only 59% actually used a good method, including any kind of method with hormones. So now the question is so there's my test again. How do you guys feel about a teenager having access to an over-the-counter? Like if she came in, would you prescribe her something if mom wasn't there? Do you feel like we need to have mom's approval? Do you feel like you can adequately coach a teenager through this decision? You think quite a bunch. All right, next slide. Keep in mind that Kentucky does have an emancipated minor law, which basically says that if you are seeing a teenager on anything related to venereal disease, risk of pregnancy, alcohol, drug abuse, or addiction, you can prescribe without consent of parents. What I usually tell them is your mom is not going to know anything about your visit today. However, she might get the bill. And on that bill, there may be a code which correlates to your diagnosis. So that way they understand that mom may still get the information, even though I don't have to have mom's permission in order to prescribe or to treat. Our next question is, some of our patients are really interested in an STD, but traditionally we had thought, I'm sorry, not interested in STD. It would be interested in an STD. They're interested in IUDs, but in the old days we used to say, oh no, they're not a good candidate because they've had PID or they have so many sexual partners. Do you have to test for an STD before you place an IUD? Is that something that you need to screen somebody for first? Or can you just place it or screen them at the day that you place it, just like swab real quick and then throw the IUD in? Well, it turns out that you can swab real quick and throw the IUD in. So basically, sexually active adolescents should be screened for gonorrhea. It is for chlamydia, for CDC guidelines. If they are at risk, they need to be screened. But you can do that at the time of the insertion. You don't have to wait until the results come back and then tell them, oh yes, you're good. You didn't have anything. Now I can put your IUD in. So you can just screen them and then stick the IUD in at the same visit. There's no reason to wait. The next slide for me. The risk of PID with IUD placement is actually pretty low. So overall, when there's no cervical infection present, and even when there is one, it's still pretty low. So it's not the old days where we used to be so concerned about PID. It's a theoretical risk and less of an risk that we actually see. Overall, I would say 1.6 cases per 100,000 women years of use. And again, you can screen at the same time. So what about teenage uteruses? They're so small. How are you going to fit an IUD in there? Do you think that teenage uteruses have more trouble with IUDs? Uterine perforation is usually the thought. You know, if you're going to have a uterus that's so small, what if I stick the IUD all the way through the backside of the uterus and I could potentially do more harm than good? Well, it turns out that uterine perforation is actually a very rare complication. So it is possible, but it's extremely rare. And if you do have one, you just give her a dose of antibiotics for a couple of days. And I usually give something that covers chlamydia as well. And then it resolves itself. The biggest risk if it's too small is that their uterus will cramp and they'll spit it back out. But just to show you how low risk this is, there was a study of 1,100 teenage women up to age 24, and successful IUD was achieved on the first attempt in 96% of patients. So it is actually pretty successful. And one of the things that we have now in order to make this a little bit easier in our smaller uteruses is we have different sizes of IUDs. So just to run through some brand names so that they'll be familiar with for you. The first IUD that came out on the market was the Paragard. So it is a copper IUD that lasts up to 10 years. But the women complained, it makes me cramp more, it makes me bleed more. I want something that's going to make my periods lighter, like the pill does. So they came out with the Mirena. The Mirena was originally an IUD that contained 52 milligrams of levonorgestrel, and that hormone was released over time in little microdoses of about 19 milliunits per day, and so 20 in this slide. And it was approved for 5 years of use, and it was a pretty small, about the same size as the Paragard. So then the next IUD that came out on the market is the one circled here, was a generic version of this Mirena. So it's called Liletta. It's generic, so it's a little bit cheaper. Instead of $900, it's about $700 or closer to $800 now probably. And when they came out, they were trying to steal the market. And so one of the things that they did was they got FDA approval for a longer time period. It's the exact same thing. It releases the hormones at the exact same rate, but they did go through the trouble of getting an FDA approval for a longer stretch. So they are now approved for 6 years of use instead of 5. Our next IUD that came out on the market was Skyla. Trying to win the market back, Bayer came out with an IUD and they said, oh, this one's better. This one's perfect for your teenagers because it's smaller. So it is about 1 millimeter small, or 0.5 millimeter smaller in diameter. So getting it in there is a little bit easier. And then it's about 4 millimeters smaller in size, so that it's less likely to be spit out with cramping. Because it is smaller, it was a slightly lower dose. And with that lower dose, we got some more spotting and bleeding. And so then they came out with, next slide, was the Kylena, which is the last one that came out on the market. It is the size of a Skyla and almost the strength of a Mirena. So it's got the size benefits of one and the strength benefits of the other. So it decreased that breakthrough bleeding problem that we were having with some of the Skylas. So that is our choices of IUDs. And then of course we also have our Nexplanon and Implanon, which is another in the arm insertional method that lasts for 3 years. So pain control during insertion. Anybody have any ideas about what you would do to control pain? Sometimes that's one of the reasons that people don't choose an implantable method like an IUD or the one in the arm. And so Brittany, if you'll hit S on your slide, It will pop up if anybody talks, it will pop up onto the screen. Some things that people have thought of in the past is, well, you know what, I should just give ibuprofen. Well, that's easy enough. Or we should try any other kind of NSAID. Maybe it's an anxiety problem. So people have talked about giving anxiolytics beforehand. One of the tricks that I do is I actually suggest that they put it in on their period. So if I have somebody who is wavering and they're not sure which method they want, I say, well, if you do want the IUD, come back when you are bleeding, because your cervix will be open up a little bit and it's a little bit easier to slide in. And I get the benefit of knowing that they're not pregnant when I put it in there. I can do a pregnancy test and they're on their period. It decreases the risk of that. So in studies, they've shown that giving an NSAID 1 hour before IUD insertion did not actually reduce the pain with the IUD insertion itself, but it did reduce the pain with the cramping that sometimes happens for about 30 minutes after the insertion. So oral NSAIDs really have not been found to be that helpful in insertion. So then somebody came up with the idea of, well, maybe we should numb up the cervix and that would help improve pain. And it also did not improve satisfaction scores because the injection of lidocaine itself was kind of painful. And then people have tried putting in misoprostol, which is prostaglandin, to help soften up the cervix, and it was also not shown to decrease pain. So basically, I think your best bet is a lot of education and counseling about how much pain there's going to be and how long it's going to last. And usually I tell them really ugly menstrual cramps, less than 30 minutes. What if she comes back in a month and says, I want my IUD out. I don't like this. I've had spotting this week. I feel like there's a foreign thing inside me. Take it out. So obviously patient autonomy is super important. My counter argument for that is we as a society have an obligation to use our money resources wisely. And you have just put in $1,000 into her uterus. And I'm really hoping that she's going to use it for more than a couple of weeks. So what I would probably do in this situation is I would do some, again, extensive counseling to try to figure out what it is that she doesn't like about the IUD and see if there's something that we could potentially solve for her. Do IUDs make you less fertile? So is it something that if you have an IUD, you might potentially scar your uterus and your uterus will be a rocky place where seed could find no purchase? I'm quoting a movie if anybody knows it.
Okay.
Or if,
Racing Arizona.
yes, very nice. Or is it one of those things where you get the IUD and once it's out, you're good to go, no issues? And you guys are correct. Once you have an IUD, as soon as you take it out, you're pretty much right back on track. If you had infertility issues before your IUD, you will afterwards. But otherwise, or if you had PCOS before your IUD, you will probably have it afterwards. But it does not actually cause any issues with infertility. There's a prospective study done, and they found no difference in pregnancy rates. What about crazy bleeding with the IUD? There are a lot of different thoughts on this. We all know that with IUDs, be it the Paragard or even with the Mirena and the other hormone-based ones, there's always a chance of bleeding. And so what do you do about it? There are some different thoughts. But one of the things that I've always liked to do is I add a little bit of estrogen back to the mix and try to see if I can get their hormones, back to what they were before a little bit. But I've found in doing a little bit of research that actually that may not be the best thing to do. Most of the bleeding over time will improve. And so again, extensive counseling, and if you can get them to ride it out, usually it'll get better. But looking at studies, there are some things that probably don't work very well. So this was a randomized placebo-controlled trial. Now this study is a little bit different because what they did was, instead of treating people who had a bleeding problem, what this was trying to prevent a bleeding problem. So they took people who were going to get an IUD, and then they gave them naproxen to see if it would decrease bleeding and spotting in the first 12 weeks, which is when they tend to complain of it most. And they found actually that the naproxen worked great. My estrogen trick of adding estrogen did not work at all. It actually increased the bleeding and spotting. And then they've also tried other things like Listada, which is tranexamic acid, and it did not help. So I think it really depends on when they're having their bleeding. If they're having their bleeding right at the beginning, naproxen might be a great way to go. If they're having their bleeding after their IUD has been in for 3 years or 5 years, it might be one of those things where you need to add back a little bit of hormones.
Can you talk about what percentage of women have significant
Have breakthrough bleeding?
Yeah.
So I would say literally 100% will have it in the first 3 months. It is so common that that it's almost universal. But then after it wears off, I would say probably about 20% of women are going to have irregular, unpredictable, I don't know what this is kind of bleeding. There's also a significant number, of course, people who are going to be amenorrheic. And the rest of the people will have what I will call oligomenorrhea, which is not predictable, but at least cyclic, I bleed for 7 days and then it goes away. So I'm going to quote you 20% risk of, oh my gosh, I'm going to go to a doctor because I really don't like this bleeding pattern that I have. So you will see it. You'll see it pretty significantly. And again, tincture of time is, I think, the best medicine that we can give, because over time the uterine lining thins out and most people will go more towards amenorrhea. But there's going to be a group that won't. And so you're going to have to address them, and naproxen may be an option in those people, or add back estrogen might be another. And my trick of doing add back estrogen is I do a little whisper dose. And so I just do like an estrogen patch, almost a hormone replacement therapy dose, like a Premarin patch or estradiol patch. And I put it on for 3 weeks, take a week off, see if she bleeds, do it for another month. And then usually that kind of resets the system and I can stop it. You could do birth control pills. You could add pills, but usually they don't want to take pills. That's why they've got the IUD to begin with. So you don't have to worry about giving them too much estrogen or too much progestin by having an IUD and the pills, because the IUD is such a low dose. It's like 1/10 the strength of a birth control pill. So you're really not giving them that much more. One of the things you might think about when you have crazy bleeding with an IUD is maybe your IUD is trying to come out. And so one of the things that we recommend is that you get an ultrasound for the position of the IUD and see if it is being expelled. And if it is expelled, or being expelled, well, what do you do? So if the IUD is supposed to be in the top of the uterus, up in the fundus, what do you do if your ultrasound says it's down in the bottom? It looks like it's close to the cervix. Well, the first thing that I would do is I would see if you can feel it. Like if you can feel the hard plastic IUD coming out, just pull it out. But if you can't feel it and it's in the lower part of the uterus, it's not up at the top where it's supposed to be, but it's not coming out either. It's just kind of in the lower uterine segment. I think the question of what you do depends on why you got the IUD to begin with. So if you gave this woman an IUD because she had crazy periods with her PCOS and she wanted better periods, and now with this IUD, it's low lying and she's bleeding every day, pull the IUD. It's not working. You didn't solve the problem that you were trying to address to begin with. But if, on the other hand, she says, no, I'm using this IUD for my birth control. Well, every bit of evidence that we have says that the IUD still works no matter where it is in the uterus. So leave it in place and see if you can solve the bleeding problem with something else, like our other tricks. There's really not any good prospective data. You'll have to go back on that, Brittany. There's only expert opinion on this, but the idea is that the IUD has a regional effect. And so therefore it's going to thin out the lining of the endometrium and be a hostile place for that sperm. And so it's going to work no matter where it is. The rates of expulsion might potentially be higher, but most IUDs actually move up over time and not move down. So hopefully it will stay in place for you. What do you do if the Nexplanon makes you bleed? As far as irregular bleeding patterns, I find that the Nexplanon is much worse than the IUDs. Most of my IUD patients, I can hold their hand for a little while and they'll become amenorrheic. Most of my Nexplanon patients, if they're bleeders, they tend to be bleeders for a while. Prolonged bleeding occurred in 16.9% of cycles, and frequent bleeding occurred in 6.1% of cycles. And again, these tend to happen not just for the first 90 days, but for a really, really long time. So what do you do with those? Usually I pretty much do the same thing. A lot of hand holding, a lot of counseling, a lot of talking to them. And if I need to, I can add back a little bit of estrogen in a cyclic fashion, 3 weeks on, 3 weeks off, and see if I can get them back on pattern again. But, you know, you could try naproxen, again, one of those NSAIDs, long-acting NSAIDs, which might also help. Birth control. Does your birth control make you gain weight? So this is a classic question that I get asked all the time by patients. I have traditionally told people that most of adults gain a half a pound a year over time. We all get gain weight over time. But the question is, if you'll go back a slide, well, just for one sec. If we are, if we're talking about specific types of birth control, I mean, obviously your Paragard's not going to make you gain weight. It doesn't have any hormones in it. Your Mirena is a super low dose, so it probably doesn't make you gain weight. That's going to be our gold standard. But the one that we're worried about, of course, is our pills, our birth control pills, and our shot. And basically we found that shots, we were originally told 4 pounds a year. But there was a study that was done in 2013 of 427 women where they compared Nexplanon, Depo-Provera shots, and IUDs to a copper IUD as their gold standard, and there was no difference in weight change. So if you are asked, does my birth control make you gain weight? You can say your relationship makes you gain weight, because a lot of women eat whatever their husbands or partners eat. What about hormones later in life? One of the best studies that I've found on this is on drospirenone, which is Yaz, Yasmin, and Angelique. And it showed that women who took this type of hormone for hormone replacement therapy or for period control actually lost weight. So it was a loss of 1.2 kilograms. It's not much, but it certainly did not make them gain. The Yasmin people have also done a study on PCOS patients, and they also showed, given a low-carb diet, those who took Yasmin actually lost more weight than those who were given placebo. So acne, one of the questions that I get a lot is, which is the best pill for acne? Well, the truth is that all pills decrease your sex hormone binding globulin, and so all pills are going to make your acne better. But one of the things that you might think about is which pill is going to be the least androgenic. If you go back a slide, yeah, thanks. So this is a very confusing and very detailed slide, but the idea is that each pill has an estrogenic effect, a progestational effect, and an androgenic effect. And if you look in the column that says intrinsic androgenic effect, which is over on the right near the blue mark, the lowest androgenic pills are going to be your drospirenone pills, which is your Yaz and Yasmin, and the ones that are made with norgestimate, which is orthocycline and orthotricycline. Both of those have very low or no intrinsic androgenic effects. So because this slide is so busy and confusing, I've given you another one. And this is the handout. If you got your email, we included this in your email that went out to everyone. And so you can refer to this, and it's a little bit easier to just quickly glance. The ones that are in your bright dark orange are going to be your most androgenic pills. And the ones that are in your super pale peachy color are going to be your least androgenic pills. And so you can just really quickly refer to this and see which pills are going to be the best ones for a patient that has PCOS or that potentially has acne or hair issues.
Dr. Cunningham, just wanted to give you a quick 3-minute reminder. About 3
Got
minutes
it.
left. Thank you.
Appreciate it. Thank you. So we're going to skip down to the next slide. What do you do if you've got somebody who's got crazy bleeding on their period? So, oh my gosh, my period is so heavy, I want it to be lighter, or I have breakthrough bleeding in the middle of the cycle. This is another resource that we will give you that basically summarizes those other charts even smaller. So now we've got just a super quick bullet list of which pills are the most androgenic, most progestational, and the most estrogenic. And so if you've got somebody who's breakthrough bleeding, you want to give them more estrogen. So you're going to pick one that's more estrogenic. If you've got somebody who's bleeding like stink when they do bleed, when they're supposed to bleed, then you want to give a stronger progestational agent. For me, I've got crazy bleeding and I'm bleeding too much. Levonorgestrel is the way to go. And that makes sense because that's also the one that they put in Seasonal and Seasonique, those long acting ones where you want to stop your breakthrough bleeding altogether. So low estrogen, low estrogen, that's usually my go-to. And then we're going to skip down one more slide to what do we do about, skip this one if you don't care, our risk of depression. So I had never heard this before. Does birth control increase the risk of depression? But I was asked by a friend, a colleague said, have you heard this, that if you take birth control pills, they did a study on soccer players and they found out that their amygdala was a different size and they're worried about hypothalamic shrinking, and they were doing functional MRIs for another reason, but they found out that this actually might be a thing. So I did a little bit of research into it and to find out, like, okay, really, what is our risk? Because I certainly don't want to put people at risk for depression. And the truth is that it's a very hard study to do because there's so many confounders. But this study, that was a Danish study, using their huge mega database that they have, they looked at women ages 15 to 34 over a 13-year period, and they excluded anybody who had a psych disorder. And what they found is that all forms of hormone contraception were associated with an increased risk of either getting depression or with getting an SSRI. And that included all of them, so including IUDs and progesterones. So what do we take from this? Clearly this is a retrospective study. So that's caveat number one. It's just, an association. Maybe there is a risk with this, maybe the progestin actually is affecting something because it included IUDs in the study. But if that was the case, you would think that we would see more of a dose effect, where if you had an OCP, you would have this much risk. And if you had an IUD, you would see that much risk. And they didn't find that. They found that use of any contraception in general increased risk of the depression. So perhaps being sexually active increases your risk of depression, or being in a teenage relationship is correlated with depression, and it is something to do with self-esteem or something along that line. So anyway, I do think it is an interesting topic that we all need to be aware of and be considering. Keep your eye out for future studies, hopefully, maybe some good prospective ones, but I do think that is something that should be on our radar. And then finally, if people have questions, please type them up. But one other thing that I just wanted to put on everybody's radar is that there's a national push right now to extend postnatal care. For those of you who went to med school here at UK, you know that every day on postpartum we're saying, hey, you should ask people about birth control. Well, the truth is that Medicaid only covers birth control for 30 days after a delivery, and then they lose their Medicaid. So this pregnancy coverage postpartum coverage is only 30 days after delivery. So we are having a national push to have longer coverage postpartum. And so you may see some things in the news about that too, encouraging better postpartum, longer postpartum care to take care of these women in their first year after delivery. So Well, thanks you guys. Sorry about all the technical issues right from the start, but I do appreciate your time and help. Resources will be coming out to you. You've already got email, including some, and then we will be happy to send along copies of slides and further resources of anything else that we can potentially have. And keep those gynecologists in your back pocket. And we appreciate all the consults that you give us.
Wonderful. Thank you, Dr. Cunningham and Dr. McKinley. We really appreciate it. This was wonderful.
Thanks, guys.
Thank you.
I just keep getting it up.